thank you, Arvind. But in this panel, we all know Arul sir has been one of inspiration for all of us, and I should never forget that I learned my basic FACO from him. So if not for him, I don't think I would have been in this platform at all. And as all the speakers have really covered things in a very exclusive, beautiful way. But we are still exploring. We want the challenge lies with the optical scientists and the material engineers to give us an unabated optical imagery at all distances. And it's more an art than science. We need to do a lot of thing to analyze before we choose a patient for the surgery. Lifestyle needs, personality dynamics, ocular pathology, vision goals, biometry, very beautifully handled by Dr. Preeti. As you all know, if we don't have a good biometry, then whatever good a surgery you're going to perform, it's all going to go hayway. And choose the right formula, what works best in your hands. We have a lot of options available. So nothing much we really very much we discuss in detail about that. But be sure about what technology you're using. And prior to that, get used to the similar technology and then get into the multifocals and trifocal scenario. And this is the most important key. And I strongly feel here, being coming out of the school of Dr. Arul sir, I think multifocal, trifocals, I think it's always that final word for the surgeon himself has got the most important say than anything else. That's very, very, very important key. Don't allow it to your counselor to do it. That's the most important, because certain smaller catches like driving in night time, a lot of unrealistic expectation we can catch from the patient's conversation with us. And we need to know a lot about this neuroadaptations, be prepared for enhancement if it is really required. And a lot of things have been dealt with the photic phenomenon. What are the factors that can compromise the surgical outcome? Significant astigmatism. Now we have trifocal with astigmatic correcting lenses, which is really amazing. And as rightly said by sir, the photic phenomenon is dramatically come down with the present scenario lenses. So we need to believe and start proceeding to it. Again, listen. The more the time we spend preoperatively with these patients, we are going to get a beautiful outcome. Most of us are excellent surgeons. So this is the one area we need to really focus very much on. Understand the lifestyle needs and visual expectations, and amount of time spent on each, and which is more important to you. So understand the work and leisure activities. These are the ones that really irritate them. And a lot of corneal pathologies need to be avoided. Aberrations, everything has been talked in depth in the previous speakers. I am not going to go into the details of which. And one thing, basically, I'm also a pediatric ophthalmologist, strabismologist. When it comes to a binocular function, see, we all know it's better to avoid multifocal in a large angle alternating strabismus, but I will not say it's an absolute contraindication, maybe a relative contraindication, because they may not enjoy the binocularity. And hyperopes with small esotropes, many times we may miss them. There's a condition called microstrabismus, microesotropia. Sometimes they can be amblopic, so there may be a catch. So the patient may not improve a good beyond 612 or something like that. So they may become a bit unhappy. If you are very sure that they have had amblyopia from childhood, these are the eyes which we need to avoid. And one-eye patients, because of loss of contrast, maybe again I'll say it's only a relative contraindication, not an absolute contraindication. So basically, it's a summation benefit of simultaneous binocular multifocal vision that will be absent in these cases. But just have a look at these things also. Always do biometry for both eyes, even if you're going to operate on only one eye. That's more essential, because you can pick up some anisometropias, difference in the refractive errors. All these conditions can be picked up when we do a bilateral biometry. That's a very, very important thing in this selection criteria. And many times, these are always being discussed, like which patient we need to choose. So the ability to perform common near activities, those criticals is advantageous for these patients. Always have a bystander with by. Many times we think it may not have any importance, but then sometimes the patient may take back their words and they may try to make an argument with you when something goes wrong. And this we all know. And the pupillary abnormalities. And I have some experience with Panoptix lens from Alcon, and I have an experience with some biotech trifocal lenses also. Most lenses are really good, and I have very limited experience with EDOF lenses, but then, they have a special technology called this Enlightened technology. And now, since now the whole world has gone into the zooming concepts, so almost everyone with a basic knowledge about entering into computers, they all depend upon Sorry, and we all need to be have to operate computers, and that's where this trifocal technology comes into play, where considering the multifocals where distant and near vision were good, here the intermediate vision is also taken care of, and there are some advantages in these type of lenses where the central button is a bit larger, so slight decentration is always can be taken care of. And this is the difference of the previous generation bifocal, multifocal lenses and compared to the panoptics lenses. And not much to go into the technological part of it. See, these are the larger diaphragmatic zone is a big advantage. The smaller zone comprises near and intermediate vision in dim light and large people. The larger zone comprises of distant vision in mesopic conditions. So this helps in all three distant visions. And always surgery, sir is very well mentioned in his steps. We need to have, starting from the incision, it should be a very nice square edged incision, and every step has to be very meticulous, whatever the type of lens cataract you are going to handle on. Many times multifocal lenses, people coming may not be the ones, the very nice PCC or a simple cataract. We may encounter harder cataracts, brown ones, and rexus marking. Always you can have a marking, rexus marking over a cornea. So we need to have a very good overlap. Whatever the surgeon is used to, a manual one or a markerless, whatever devices, but be very perfect on your rexus marking. A perfect centered rexus is always very essential. And wherever required, dye to be injected, because when we have when you're operating on a luminescent lens, and these are the areas where like we may go wrong with the rexus. The perfect central.
Dr. Ramesh sir, please unmute yourself. You are muted.
Yeah, is it okay?
Yeah, fine, sir.
Meticulous polishing of the posterior capsule is essential because these can result in unhappy patients in immediate post-op. So we may be a bit hesitant to do a YAG cap for the fear of subtle CME and all such complications which do not want to happen in a high-tech patients. What's happening here? And visco wash from underneath the IOL, that's the most important thing, because we want to have a good adhesion between the lens and the posterior capsule. And if there is an anterior capsular tear, are we going to go ahead? Yeah, maybe in simple trifocal lenses, yes, still we can go ahead with the surgeon, it's a surgeon decision, but maybe controversial in case of a trifocal toric lens. Smaller ZDs, spiraling of rexus. For the want of time and just skipping these videos. Is PCR a contraindication? Maybe if it's very well managed, maybe still it can be still performed and still be able to place the lens in the back. Small eccentric PCR in this case, well managed. PC dehiscence, if you are good enough, we can still perform a posterior PCCC and still we can implant the lens in the back. And a long time back, my dad, he's an ophthalmologist, 82 years, very happy having a latest technology implant. And the reading speed of one patient, I still remember the moment she came out of the operation theatre OR, she just suddenly started reading her own this thing. I just recorded this. So patient's testimonial. And so that's it. Like that's experience I just want to share with you. Thank you. Thank you.